Okay,
Okay.
have we got enough in it yet?
Yeah, I think we're ready. So I would like to start off with a land acknowledgement. And So although we're meeting virtually, we acknowledge that Baycrest and our related BSO family and behavior support programs throughout the province operates in the traditional territories of many indigenous nations, which have cared for the land for thousands of years, including the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. We recognize the current treaty holders, the Mississaugas of the Credit First Nation. This land remains home to many diverse nations, Inuit and Métis people, and is subject to the dish with one spoon, wampum, and agreement to peacefully share and care for the Great Lakes region. We're grateful to have the opportunity to work on this land today. You may live and work in different territories, so we encourage you to reflect on the land in which you are located and to consider your relationship to the land and to the people who are the traditional keepers of the land. This calls us to commit to continuing to learn how to be better stewards of the land we inhabit as well. This acknowledgement is a simple, powerful way of showing respect and a small step towards correcting the stories and practices that erase Indigenous people's history and culture across Canada and here locally, and towards inviting and honoring the truth. We are deeply committed to the truth and reconciliation process. So I'd like to welcome Professor Cristine Rego. She's from the Lac Seul First Nations and is a registered social worker. She's a private consultant in private practice with Nojimo Health, and she teaches full-time in the School of Justice and Community Health at Fleming College, and her research interests include intergenerational trauma, violence against women, traditional healing practices, culture safety, and addictions and mental health. So welcome and thank you for coming to speak to us today, Chris.
Thank you, Marilyn, and thank you everyone for joining today. You know, it's always an auspicious day when I speak, particularly even though it's not the 30th, recognizing tomorrow is Orange Shirt Day, and you know, we're wearing orange in honor of that. I had to quick change. I had to be a quick change artist to get it all in time. But I'm glad to be here, and I'm going to continue with my I have to go through the disclosure templates here. It says where I am, you know, I don't have, not receiving any financial support, there's no in-kind support, no conflict of interest. So we need to get that business out of the way. And the information presented in this program is based on recent information that is explicitly evidence-based. So lots of work on trauma-informed care out there and has been for a number of years. And the Behavioral Support Rounds program and its material is peer-reviewed, and all the recommendations involving clinical medicine are based on evidence that is accepted within the profession. And all scientific research referred to, reported, and used in the BSR activity in support or justification of patient care recommendations conforming to the generally accepted standards. So I want to say welcome, Ani Bojul, Wasian Kwat Kwe, Dejnakaz, Nindo Jaba, Jaba, Lac Seul First Nation, Ninda Peterborough, Moose, Denodam. And so what I said is hello. My spirit name is Wasian Kwat Kwe, which means bright cloud woman. My Christian name or given name is Cristine Rego. I'm from, my home is Lac Seul First Nation, and I'm currently living in Peterborough, and I'm part of the Moose clan. And we introduce ourselves in our language, first because we lost our language as Indigenous people as a result of colonization. And learning, and some of us had to learn to get our language back, and it grounds us in our identity in terms of moving forward in who we are, which is very important when we're talking about trauma and cultural safety and trauma-informed practices, because we need to understand that there's a prevalence of trauma, particularly with Indigenous peoples. So I have talked previously on this forum about trauma-informed care, and with the intention of improving people's understanding of what trauma-informed care is. Today, I'm not going to be going over what we have talked about in the past, but rather moving that forward and spending time on putting trauma-informed care into action and referring to the action as calls to action. And in the context of Indigenous, we'll be talking about the 13 calls to action, drawing from the 13 spaces on the turtle shell. And from that, we'll be focusing the calls to action within the 4 R's: respect, relevance, reciprocity, and responsibility. So in the context of two-eyed seeing, Anishinaabe, I'm Anishinaabe. So the Anishinaabe and Haudenosaunee people use the back of a turtle shell as a lunar calendar. And the moon goes around the earth in approximately 28 days, which means that in 1 year, we've got 365 days. The moon's going to travel around 13 times, giving us the 13 lunar moons with 28 days. And this same pattern is on the back of a turtle shell. And we use this for cultural teachings of the cycle of life, the different moons and activities associated with each month, and also used for teaching about turtles and what they represent. And October is known as the freezing moon because we had the harvest moon, and now we know that a cold weather is coming and we're engaging in all kinds of activities to prepare for that. So when I talk about the context of which trauma-informed care and our teachings today, they're couched in Indigenous understandings and how we apply them in what we call two-eyed seeing, 2 perspectives. So the medical model and traditional ways of doing. Excuse me, I'll be pulling from the work of Kirkness and Barnhart to provide a framework for the calls to action. And by calls to action, I'm referring, as I said earlier, to the action part of trauma-informed care. And as I talked earlier, I want to take this further and discuss some of the changes to the organization and the way we work that will ensure we deliver services, engage in a way that embraces trauma-informed care principles. The Trauma-Informed Care Implementation Center defines a trauma-informed approach to care as one that acknowledges that healthcare organizations and professionals need to have a complete picture of a patient's life situation, past and present, in order to provide effective healthcare services with a healing orientation. What we should not be doing in any way is re-traumatizing an individual who is accessing services or supporting someone accessing services. And we've all heard stories about people accessing services and it's gone south very quickly. In some cases, terminally, negative results, and in other cases, bad experiences of how Indigenous have been received at a particular organization. And, you know, across the nation, we hear different stories happening. And we understand that when those things happen, that's not trauma-informed care, even though we may know the lingo and we've had some education on it. We fall short sometimes in putting our understanding of trauma-informed care into action. And we need to change that if we're going to improve health outcomes, particularly for Indigenous, but for anyone who has a history of trauma. So trauma-informed care seeks to realize the widespread impact of trauma and understand the path for recovery. It recognizes the signs and symptoms of trauma in patients, family, and staff. And it integrates knowledge about trauma into policies, procedures, and practices, and actively avoids re-traumatization. And sometimes, you know, when I say the integration about trauma into policies, procedures, and practices, in black and white, it can look like we're doing what we're supposed to be doing. But in practice, we may not translate that into practice that isn't re-traumatizing individuals. And I just had to think about an email that I got from my own supervisor that said, you know, can you please set up a time to go in my calendar and set up a time to meet with me about a concern regarding whatever. But it was so vague. I got stressed all over. And I thought, and I, you know, I recognize it and stop it. That's a trigger. Have to understand that every time I go into a meeting with someone in a position of power over, regardless, as an Indigenous person, it doesn't necessarily mean a bad thing. And so even something as simple as sending an email to someone, or even a phone call with a vague message, and we know what happens. Please call the office. We want to discuss a matter. That can trigger someone that has a history of trauma. And for an Indigenous person, we know that if we go into a meeting and the door is shut, if we go into a room and the door is shut with someone in a position of power over, bad things can happen to us because the history has taught us that. And so, but knowing the history of trauma and understanding trauma-informed care principles, I can override that anxiety. And we know that trauma memories sit on the right side of the brain. And regardless of whether the left side is trying to tell us it's not happening, the right side thinks it's real time. But I know that, and I can override it. But with someone who doesn't have that understanding, if they're triggered in maybe how we greet them, the physical space around, how we engage them, how we interact with them, we could trigger them, and they can be triggered into what they think is real-time trauma. And so we have to make sure whatever it is that we do avoids that re-traumatization for individuals. So being trauma-informed care can help us change the message from what is wrong with you to what happened to you. It's amazing the results that we can get when we send a message that what happened to you, which is not cold language, it's warm language. We're recognizing them as an individual versus them as someone that has something wrong with them. You know, the medical field has so many gifts to offer us, and you know, and very specific, very you know, timely in many cases, but sometimes we get lost in how we do our work by sending the wrong message. And when we can change that message to what happened to you, we're sending a message that is strength-based. It's saying that we value that individual as a separate entity, as someone who's important enough that we can help them maintain their dignity by not making them a victim, just by the simple use of language that's strength-based versus sometimes our language can be very cold in how we say things. I know even when I'm teaching future practitioners when ready to go out in the field, that I tend to stay away from patient and client for the simple fact that they can be colder words versus using the word the individual that you're helping, or calling themselves a helper versus a practitioner. They're just warmer, strength-based words. And the language we use in and of itself can change that message in a very powerful way and make the individual feel more comfortable and safe to be able to share what it is that they need to share in terms of them being able to move along on their own healing journey. So what do we need? Well, we need a system that respects those accessing services for who they are, that is relevant to the worldview, that offers reciprocity in their relationships with others, and that helps them exercise responsibility over their own lives. Respect, relevant, reciprocity, and responsibility. And think about how do we do the work that we do now? Are we following those four R's? I think of my mom when she moved from a remote First Nation community because she had vascular dementia and then eventually stage 4 cancer, and she was living with me. And, you know, doing the standardized testing to see where she is, you know, the level of dementia, and having pictures that weren't even relevant to her worldview because she lived in such a remote community that sometimes the pictures didn't fit with what her understandings of the world are. And so that, you know, can create a false reality. And so we have to know that when we're doing the work that we're doing, that it's relevant to that individual's worldview. The reciprocity in the relationship with others. When we think of how do we do that? How do we ensure reciprocity? And what is our understanding of reciprocity? You know, for Indigenous people, we understand reciprocity is that, you know, we treat people the way that we're treated. And if someone is kind and gentle, which is one of our teachings, that we have a responsibility to ensure that everything that we do respects all living things around us. And so that, you know, we've all experienced, you know, going to an appointment and maybe it's really busy and someone's phone won't stop ringing, and maybe they're a little tired, maybe they got things going outside of the workplace that we don't even know about, and maybe their manner might be a little shorter than what they didn't intend it to be, but that can be off-putting and it can make someone feel not safe. So we have to understand that we have to maintain someone's dignity and be compassionate and authentic in how we engage with people. Because if we expect them to put their trust in us as helpers, regardless of the position we have in that organization, then we have to understand that how we engage with them is going to allow them to have that reciprocity and follow their teaching of reciprocity. And in turn, when we honor the respect, the relevance, and reciprocity, that we and give them some control. So when we think of cultural safe practices, and we know that cultural safety is a component of trauma-informed care, we also understand that we have to address the power differential that's inherent in the helping relationship. And we have to understand that they are the expert on themselves. They will know what's going to work for them. We can pull all kinds of tools out of our tool bag and say, you know, here's some of the things that we can do. What do you think? Versus, here's what I want you to do. It's a very different approach. And so that if we give them the opportunity to exercise responsibility over their own lives, and we provide that supportive and safe environment in order for them to be able to do that, and we allow the time to build a trusting relationship, because that trusting relationship can take time to build. And if you think, for hundreds of years, Indigenous people have followed what medicine has told us to do, not our traditional medicine. And we haven't seen much of an improvement in our health outcomes. So we have to learn to trust that. And because of the history of colonization, there needs to be an understanding that given the right set of circumstances and the opportunity to be able to exercise that judgment, that we in fact can be responsible for our own lives and make decisions that are in our best interests, because we have hope when we have respect, relevance, reciprocity, and responsibility in the way that we access services, it gives us hope for change and new beginnings, and it gives us hope for future relationships. And when we think of change, we know we've all been in organizations at different capacities, and change can be implemented, and change can be hard. And there's hard questions about change in the context of trauma-informed care. What's all this talk about trauma-informed care, and what are they expecting me to do differently? we only got so many hours, we got so much work to do. Now you're going to put this on top of it. It can create some distress within individuals. Change is stressful enough, never mind being specific. Why do organizations continue to perpetuate policies and practices that have not increased positive outcomes for Indigenous? Why have they not? We know that they're coming in at the bottom of the social determinants of health. So what can we do to improve their health outcomes? And how is it that organizations fail to recognize the de facto or actual forms of institutionalized discrimination? And what are some of the barriers or obstacles that need to be overcome? Sometimes we're so used to doing things the same old, that we don't realize that institutions themselves can be very much a part of institutionalized discrimination. So Kirkness and Barnhart talk about infatuation with the status quo, comfort in doing what we know has always been done. And while their work is in the context of trauma-informed care and education, it's important to remember that trauma-informed care came out of medicine. And the impact of trauma was recognized in the 70s as a result of post-traumatic stress disorder with veterans from the Vietnam War. And the link with medicine came about after a landmark study in 1997 and in Fleming, which surveyed over 17,000 adults about their exposure to 10 categories of abuse, neglect, and household dysfunction during their childhood. And the study is known as the Adverse Childhood Experiences, the ACE. This is, using the ACE. Many of us are familiar with it. And this particular study took 2 years at using the survey of physical exams and ongoing tracking of the adult's health. What they were able to show was that there is a strong correlation between childhood trauma and poor health outcomes decades later. So what does that mean in the context of trauma-informed care in the health field? Well, quite simply, it means that whatever we do, how we engage, how we interact, must ensure no further traumatization within the best of our ability, physical interventions aside. And so we know that a young child who experiences a physical medical intervention before age 3 experiences trauma. But trauma comes in many forms at different ages and stages of life. Understanding that many people walk with a history of trauma begins a process of engaging in service delivery that embraces trauma-informed care principles and practices. Adopting trauma-informed practices can potentially improve patient engagement, treatment adherence, and health outcomes, as well as provider and staff wellness. And it can also reduce avoidable care and excess costs for both the healthcare and social service sectors. What are some of the challenges that we experience? Well, as I said earlier, people naturally resist change. One of the questions many workers will ask when we're talking about change in an organization, is this going to require more work? creating a trauma-informed organization, it's a fluid, ongoing process. And doing trauma-informed care and making those changes will require an ongoing process. You have to remember to promote, not announce. Just don't be announcing we're now going to be, as of Friday at 3 o'clock, we're going to be a trauma-informed organization. No, we're going to promote the advantages to being a trauma-informed organization. We're going to promote why it makes sense that as a service provider, whatever capacity within that organization, that there's a benefit to being trauma-informed. And you're going to engage individuals who are open to change so that they can act as advocates. Sometimes it depends very much on how change is embraced, depending on who the messenger is. And we know that. And what else do you want to do? You want to offer opportunities for discussion, and you want to have input from staff. It's no different than we talk about including the client in their care, client-centered care. It's important for staff to be able to have input so that they too can feel that their voice has been heard. So trauma-informed care may be cost-effective, leading to less intensive services and less use of services, getting to and addressing the issues, has the potential to prevent undue stress to staff members and clients due to understanding trauma. We can prevent client crises caused by old policies that could re-traumatize trauma survivors. So what do organizations need to be? They need to be trauma aware, which is the respect. They need to be trauma sensitive, which is the relevance. They need to be trauma responsive, which is the reciprocity. And they need to have trauma-informed access, which is the responsibility. You see the 4 R's coming out when we're looking at this now. So let's look at be trauma aware. So one of the things that one needs to do is respect that there's more than one way of doing. We need to provide education and training sessions. These are your calls to actions now, they're coming out. You need to provide different formats for learning because there's different ways of learning. And what is trauma? What is trauma to application and delivery of services? So you need to understand what is trauma, and then how, along the spectrum to how do we apply in delivery of service. That's your 4 things that we can do, 4 calls to action to be trauma aware. To be trauma sensitive. By understanding the extent to which trauma is prevalent, it reflects on the awareness of the relevance of a trauma-informed care organizational strategy. If trauma is so prevalent, then it makes sense that we have a response in an organization that is trauma-informed. If we're going to be trauma sensitive, we need to be authentic in welcoming and supporting, so those accessing services feel cared for, safe, and respected. We need to have trauma-informed care across the organization, including ensuring non-clinical staff, such as the front desk workers or security personnel, who often have significant interactions with those accessing services and can be critical to ensuring safety and well-being, that they're part of it. That it isn't just one thing we're doing, but that all people involved understand what trauma-informed care principles are and how we put it into action. And then to be trauma responsive. All staff are able to apply trauma and care knowledge and skills in day-to-day work. You aim for this as a goal. And that all staff are able to reframe behaviors in their own minds as well as for others. Sometimes we just get so caught up and we need people to help us see it maybe a different way. And we need to be open to that and not take it personally. All staff are able to review policies and practice in order to ensure that they reflect trauma and care principles. You want your staff to be able to do that. You need to have the policies and practice that are trauma-informed care in order for them to be able to review them and practice them. All staff are able to model trauma-informed care in their interpersonal interactions. And reciprocity refers to the mutually responsive quality of caring relationships. We need to ensure and provide necessary supports for everyone. If I, as an employee, am struggling to understand and implement, then I need to know that my organization is going to help me be able to do that. Or not be punitive, but be supportive, you know, because my learning curve might be very different than someone else's. And so we need to be able to be accountable to ensuring that flexibility for individuals in being able to not only increase their own awareness, but then to transfer the knowledge they have into action and to support them as they do that. Trauma-informed access. The physical environment is important. The principles of trauma-informed design include reducing and removing known adverse stimuli and environmental stresses, actively engaging individuals in a dynamic, multisensory environment, supporting self-reliance, providing and promoting connection to the natural world, separating individuals from others who may be in distress, reinforcing a sense of personal identity and promoting the opportunity for choice while balancing program needs and the safety and comfort of the majority. And these are strong words. And I can think, when I think of a physical environment, and I think of going to a child welfare agency, and it was an indigenous one. I was doing some training on, of all things, trauma-informed care for their agency, for workers. And at one point I had to walk through the door, one particular door, and it slammed behind me and the lock clicked in place. And I immediately went to the trauma side of my brain, went to Kingston Penitentiary. And I worked at Kingston Penitentiary as a female guard in the early 80s after I graduated with my undergrad, and they were looking for a university educated female to change the image of the guards in the federal correctional system. So they hired a whole bunch of us. And it was a tough environment. And that door locked behind us every time we began our shift. And we were in there with the worst of the worst in Canada. Kingston Penitentiary had the worst of the worst. And it was always in the back of our mind, you know, that there could be a hostage taking, there could be a riot, whatever, always. And for someone with a trauma background, experiencing that and then fast forwarding to, a different kind of work and walking through that door, walking through a door that banged shut behind me and I heard a lock click, triggered old trauma. And so when I say physical environment is important, that's just one example of how it can trigger someone and that we would never anticipate, because we have locking doors closing behind us in many of our institutions. But we don't realize what that does. Ringing of bells for residential school survivors, if they hear a bell, it takes them right back because bells were rung in the residential school. Walking into an organization that has plexiglass and you have to talk through a little wee hole and a really cold, the Even the covering of the furniture is vinyl, which is cold, right? And not very comfortable. There's no water cooler. Take a look around at the physical environment of what you're walking into. Just yourself as an employee, and see, is this welcoming? Does this feel safe? You know, many of us in our day-to-day, we just walk along, right? We don't think about, is this comfortable? Is this safe? You know, we have shared office space, but you know, my shared office, my half of the office looks very different than my office mates' half of the office. I just have to look over there and it just feels a little colder, but over on mine, I got personal things. I got things that are reflect my culture. I have little thank you notes hanging on my board. They're reminders, they're warm. You know, I have a shelf with water and soft drinks on it. So if someone comes in and wants a drink, they're handy right there. The physical environment is important. Lighting is important. Spaces with clear sight lines and few barriers create a sense of safety and calmness. If it's all broken up, you can feel really caged. Darker hued colors contribute to arousal of negative emotions, while there's a calming effect with cooler colors. Well, we know that. You need to create visual interest, but not overcrowding with items and images. Like, don't go on all, you know, remember, my grandson's stepmom painted his room. Said, oh, I painted the room, come and have a look at it. And I looked at it, and I physically just went like this, because there were like black triangles and white triangles and gray triangles on 3 of the walls. And it was too much. It made me uncomfortable. It was overstimulating. So when we say don't overcrowd with images or items, that's what we're talking about. It can be too much. People with histories of trauma have to feel safe. And if you overstimulate, there's too much. But remember, they're always hyper sensitive to their environment, even if they don't realize 20 years later that they're still doing that. And it can create uncomfortable feelings. So furniture, as I said earlier, should be durable and easy to clean, and the arrangement should enhance safety and promote a positive relationship with staff. I'm laughing because I think about walking into waiting areas where you just got one long couch and there you sit, and you really don't, what do? You face the plexiglass window where the workers sitting, answering phones, greeting people, and there's a clear physical separation, and you have nothing of comfort around you. And I just think how cold that is, and how, it brings back images of sitting outside the principal's office on the hard wooden bench, because maybe you're being called down to be disciplined for something. It doesn't bring back those kinds. When you think about, when we say the arrangement should enhance safety and promote a positive relationship with staff, you need to go back to the top. Spaces with clear sight lines and few barriers. That creates a sense of safety and calmness. If you want a room to appear less crowded, have natural light, and remember, lower lighting helps to reduce stress and discomfort. I normally don't have my office this bright because I have, 1, 2, 3, 4 lamps that I have on, but they're all soft lighting and they're all strategically placed because I want people to feel comfortable and feel natural. I don't even have natural light coming in. I have one wall that's pretty much all glass, but the glass just looks out onto a hallway. But I'm not in control of that. But I can control it by having things in my space that make it more calming. If you can have real plants, because that connects to the natural world and improve the mood. I mean, if I've had offices where, two walls have been all glass and I just look outside into the natural environment, and that's been wonderful. But I'm not in a place where I have that, and I don't even have real plants in my office because, well, they would die. But if you can have them, it connects to the natural world, and it improves mood. You know, I think of when I went up to Sioux Lookout to visit their hospital, and because there's so many indigenous people, it's right in the heart of indigenous country. They had the palliative wing. Their walls, the one wall was all glass, so that the people that were there could be wheeled over and feel like they were part of nature by looking out on the window. It's amazing. That's being trauma informed, right? Because we lost, indigenous people lost their land bases, and being able to be part of nature is very grounding, and it improves our moods. I talked earlier about avoiding loud closing doors because they can be a trigger for some. And those are the references. You know, if you want to be going back and looking and saying, what was Chris talking about? What does she think she's talking about? But I want to say Miigwech, Chi Miigwech, always an honor. And I guess we're open for questions, Marilyn.
Okay, thank you, Chris. Yeah, there are some questions here. There's from an anonymous attendee. Have there been discussions with education at elementary, high school, and post-secondary levels about trauma-informed care, particularly with educators of future healthcare providers and clinicians? So education is at the grassroots level of learning may facilitate changes over time to reduce the incidence of institutional clinical setting and induced triggers.
Oh, that's a really good question. And I can tell you that I know of some school boards at the primary and high school level who are educating their staff on trauma-informed care principles. I know in our program here at Fleming College, in the social service worker program and the mental health and addictions program, I do a whole series on trauma-informed care so that the emerging professionals have that understanding when they go out.
Thank you, Chris. So from Sherry, would there be any different approaches perhaps for older individuals who have not experienced trauma, but who now are also experiencing progressive cognitive decline?
And you know, that's an interesting question, because we had started to research pre-COVID, and then COVID happened, and the funding stopped. We had started with the question, the hypothesis that there is an increase in sundowning, particularly with indigenous, because of the history of trauma, intergenerational trauma. You know, which comes with a whole set of challenges. In terms of trauma-informed care and people, how we work with people, you have to ensure that they're safe and reassure them that they are safe, because it's really no different. You're just doing it on a more regular basis. You know, I was blessed that where my mother was, that the staff were so inclusive and concerned about her, and very helpful and supportive. But I remember even talking with her and having to convince her, even when she lived with me, that she felt safe because around the corner down the street, there was a police officer and his family living there. And that reminder that there was police so close made it easier for her. So, you know, the approaches are going to be very similar in how we do it. It's just that you may be doing it more often and probably more critical, so you don't add to incidents of sundowning because they have that history of trauma.
Okay. And one of the things I take home messages from last year's talk, Chris, I remember you mentioning even the words that we use in the setting of long-term care. Instead of using the word resident, which can be very triggering to use the word, person who lives there.
Yeah.
Sort of, those sorts of things that might be helpful in our practice.
Yeah.
Okay. So, Cristine, so thank you for the session. It's so informative. I appreciate you speaking openly on this and helping us learn about trauma-informed care. Are we can connect with you by email? So are you willing to share your email information?
Yeah, by all means. Do you want me to type it in, or you want to type it in? It doesn't matter to me. I'm open for people to email me for further discussion and for, if they have any questions. One thing you do need to know is that myself and Dr. Catherine Irvin are writing a chapter in a book on trauma-informed care that's, we have to have our submission in by November. They always take a little bit of time. So I anticipate next year they'll be releasing a book on trauma-informed care for educators, staff, and students in education institutions. So the principles that we're talking about are going to be applied in a specific situation.
Okay, thank you. Are there any other questions? Does anybody want to come on camera live to ask a question?
It looks like there's a request for the resource slide to be shared again. And then there have been other requests coming in about the slides and the recording. The recording will be available, and typically the way we've done it is I've sent it out to those who have requested it from me rather than sending it to everybody. So you're welcome to send me an email with your hand raised and say, I'd like their recording, and I'll send it to you then. So my email is in the chat as well.
Okay, good. Yeah, and I thank everyone for the kind comments. We always go into these things thinking, geez, do I have the right information? Do I understand it in a way that I can transfer the knowledge that's going to be useful? And I know, even being a practitioner, even though I don't like the word, or a helper out in the field, is that, theoretical models are great, but they never have the how-to, and the calls to action are necessary for us to help us do our work in the best way that we can, that's going to be inclusive and equitable and safe.
Okay, there are a couple of people that have raised their hands and I can't see them now. So if you just want to shout out your questions, I'm not sure, Agnes, if that's possible.
Hi, Marilyn. No, this is a webinar, so participants have to type in their question either in the Q&A or in the chat. Okay.
So, Sherry mentioned that she's, grateful for the presentation. It's been a clinically informative session. One of the most clinically informative sessions that she's attended in some time. So your point about relevance to all persons who have experienced trauma was really appreciated. And as we know, there are many survivors of various types of trauma situations. So the information was very helpful. So lots of good kudos in the chat box and the question and answers there.
And you have the slides to share, right? Because you've recorded it?
Okay. Yes.
Yeah.
Okay. So I also want to mention to thank the CLRI, so the Center for Learning and Innovation at Baycrest, for sponsoring this event today, and in collaboration with BSO. And Anna, maybe you have some acknowledgements for our geriatric addiction rounds as well. And
sure. The Centers for Learning, Research and Innovation in Long-Term Care help make this possible. Also with the Canadian Mental Health Association of Waterloo Wellington, St. Joe's Health Centre in Guelph, the Behaviour Support Ontario, the Centre for Addictions and Mental Health, and Baycrest Hospital BSO. So lots of people came together to hear Chris present to us.
So, and thank you very much, Chris, for your really very thoughtful presentation. So we will have the recording available, and I'll be sending it out to those of you who are from the Meta-Fi listserv as well. So we have our geriatric addiction round starting up next October the 11th. So we'll have a speaker on cannabis and treatment approaches, I think. So so hope you can come out to that. And the other thing is to acknowledge that tomorrow being a National Day for Truth and Reconciliation, if you to acknowledge the day, if you're going to buy t-shirts, buy t-shirts from organizations that are actually helping people who are survivors. So I don't know, Chris, if you've got a pitch for a particular organization that you want to mention.
Yeah, just, you know, when you're buying one, ask who it is so that you know it's going to one. There's lots that are reputable, you know, and I, in all fairness, can't put one over another one, right? But there's also, like anything, be wary of the ones that are in it just for direct profit.
Exactly, yeah.
I can't tell you those ones, but I know they're there.
Yeah. Okay. Okay, are there any other questions? We'll just have one last ask of the participants. So
I do want to say I'm glad and pleased and honored that you found this very helpful. I know that I like to have, you know, the how-tos, or how we say call to actions, because it's really important. It's nice to be told about something, but to understand how to do it makes it a little easier to be able to incorporate it. So I share that because I learn it and transfer the knowledge, because that's how knowledge should happen.
yes, thank you. That's very important. Okay. Well, I think then we will again thank you, Chris, for your wise words, your presentation, excellent presentation, and we'll give everyone the gift of time. And so you'll see in the chat box lots of kudos and thanks, Chris, for the wonderful presentation. So
Miigwech for the opportunity.
miigwech. Okay.
Thank you.
Thanks, everyone.